hear me? I hope so. It's always daunting to follow Nicole because, number one, I don't have more to say than she does. And number two, everything I have to say, she has already said and much better. So if you, for some reason, drop off this, I just second everything she said. There's nothing she said that I disagree with. That's number one. Next slide. All right, so I have a couple of disclosures. I did write these two books, General Public, Fat Chance, which is about diet and physical health, Hacking of the American Mind, which is about diet and behavioral health. And I'm also the chief medical officer of a nonprofit called Eat Real. We're trying to get real food into schools here in the United States. Actually, I am not in the United States right now. I am in Paris. So bienvenue, everyone. Okay, next slide. This is not working, Esther. There's too much of a delay. Is there a way to fix this, make it so that I do have control or can get my slides to work? What? This is not a good answer. Hello? How and why? And is this true of all foods? Is it true of only processed foods? Is it true of sugar-containing foods? What are the specifics? And that's what we're going to, and why is it that there seems to be so much controversy about this? That's what we're going to be talking about today. So is food addictive? Well, the lay public seems to know this, but the scientists are actually having a hard time coming to some sort of consensus about it. So Nicole presented to you the Yale Food Addiction Scale, and you can see here that it was originally applied to study food addiction by Kelly Brownell and Ashley Gearhart. And primarily it is through retrospective questionnaires as opposed to any sort of imaging evaluation. It does, however, correlate with neuroimaging. As you can see here, the food addiction scores in the do correlate with activation with fMRI of the nucleus accumbens, the reward center. So there certainly seems to be temporal relation between the two. And it also appears that palatable food triggers these areas very specifically. When we say palatable food, we'll get into what that means in a minute. In addition, we also have some data that suggests that the greater the reward, the more likely that there will be increased BMI Z-score increase over the course of time. So that suggests that there is a dose response between the palatable food, the nucleus accumbens, and a behavioral correlate, that is weight gain. So this, of course, has led to this concept of food addiction, which has been around for probably about 10, 11 years. Mark Gold, chairman of psychiatry at the University of Florida, Gainesville, first brought this to the fore in 2009 and again in 2010. But interestingly, by the time 2012 rolled around, he stopped talking about and started talking about food and addiction, like these two things were actually dissociated in some fashion, that they weren't actually the same thing. And the question is, why was this? And it actually had to do with this paper that was written about this whole concept that appeared in Nature Reviews Neuroscience out of the UK. So Paul Fletcher is a psychiatrist. Hisham Ziauddin was his fellow, and Sadaf Faruqi is a pediatric endocrinologist and geneticist who has studied the leptin pathway. And they wrote this opinion article called Obesity and the Brain, How Convincing is the Addiction Model? And what they said was that there was not that much evidence linking addiction and obesity at that point. And I would actually argue that they didn't quite get that right for a couple of reasons, which will become apparent over the course of this talk. To which Nicole, she didn't show this, wrote this editorial, this letter back from that review, which I found just fascinating. Tossing the baby out with the bathwater after a brief rinse, the potential downside of dismissing food addiction based on limited data, which she also co-authored with Ashley and Mark. To which then the Fletcher group at Cambridge published this one saying, food addiction, is there a baby bathwater? As you can see, this has been highly contentious on different sides of the Atlantic. So to make a long story short, in America, we do believe in food addiction, whereas in the UK and in Europe, the concept has been somewhat more difficult to elaborate. Now, one of the reasons for this is shown in this paper that from this group called NEST, which is throughout the UK, not just UK, sorry, throughout the EU, although there's a large in the UK, is that eating addiction, food addiction, and this matters because if it's eating addiction, then the onus is really on the individual because of their choices, as opposed to if it was food addiction, where the onus would be on the industry because it would be something they did to the food. So this is not just a semantic argument. This actually has a lot of importance in terms of how one deals with it. So the question is, which one is it? Is it eating addiction or is it food addiction? So if it's about obesity, which is what Fletcher and his group said, and if it's about eating addiction, which is what NeuroFast says, and if there's no specific foodstuff that is addictive, but it's a quantitative rather than a qualitative effect, well, then the food industry has carte blanche and there's no option for any form of societal intervention, which has been necessary for every other addictive substance and behavior. So education alone has not solved any substance of abuse, and it has not solved any behavior of abuse. In fact, that's why they're addictive, because the biochemical drive to use and overuse is greater than anyone's cognitive inhibitory control over it. So for every single substance and or behavior that we have identified, we have two phenomena that have to go on. One is called a personal intervention, which we can call rehab. And the other is societal intervention, which for lack of a better word, we can call laws. Rehab and laws, rehab and laws. If the NeuroFast group is correct, then there will never be any laws because there's no such thing as food addiction. So this matters a lot. This is not a little thing. So let's talk about what NeuroFast says and what they believe. So this is actually from their website, as you can see, and I want to focus on a couple of statements that they make. They say, current evidence does not allow us to conclude that a single foodstuff versus via a single specific neurobiological mechanism can account for the fact that people overeat and develop obesity. Now remember, they keep bringing up obesity. Obesity is the wrong marker. And I will tell you right now, that is not where we should be going. Okay, we could be talking about diabetes, we could talk about cardiovascular disease, we could talk about some other thing. There are a lot of things that cause weight gain, not just processed food. But when we talk about diabetes, we're talking about something much different, and the data is much tighter as well. So keep that in mind. You know, they talk about obesity. Second thing they say is in humans, there is no evidence that a specific food ingredient, or food additive causes a substance-based type of addiction. And then they qualify it by saying the only currently known exception is caffeine. Now, they already have an exception to their statement, which is already interesting. So yes, they admit caffeine can cause addiction, and caffeine is a chemical, and caffeine is found in food, yet they're giving it a pass. Next statement. Within this context, we specifically point out that we do not consider alcoholic beverages as food, despite the fact that 1 gram of ethanol has an energy density of 7 kilocalories. In fact, alcohol is energy, and therefore food is energy, therefore alcohol is food, except they're basically discounting alcohol as well. So this is very interesting. They've already now discounted caffeine and alcohol from their thesis and from their analysis. And lastly, it says, addictive overeating is clearly distinct from substance use that causes addiction via specific mechanisms. And I'm not sure that that's true either, especially after what Nicole has told you. So, NeuroFast exempts both alcohol and caffeine, even though both are in food. So, now let's talk about the science. Let's talk about what we know and what we don't know. So, on this slide, you will see here the hormonal and neural pathways that contribute to energy balance, in other words, obesity. In the blue, you see 4 hormones: leptin, insulin, ghrelin, and peptide YY3 to 36. Each of these hormones is released from its peripheral cellular phenotype in the adipocyte, the stomach, the small intestine, and the pancreas. Each of them travel to the brain, enter the brain at the ventromedial hypothalamus, which transduces those signals and has receptors for each of those. And then that information is gated through a set of neurons, the POMC neurons, and the propium, melanocortin, CART neurons being on one side, and the ghrelin positive and PYY positive neurons on the other side, leading to activation of these 2 way stations in the hypothalamus called the paraventricular nucleus and lateral hypothalamic area. And then these are where the melanocortin 4 receptors are located. And from there, that information is then brought down via the medial the medial longitudinal fasciculus down to the dorsal motor nucleus of the vagus and the nucleus tractus solitarius. The dorsal motor nucleus of the vagus is the origin of the vagus nerve, the efferent vagus, which innervates the entire abdomen, including the pancreas, the small intestine, the stomach, and the liver. And that is carrying one set of information. And the other is the locus ceruleus, or LC, that you can see there. And that is the source of the adrenergic system. And it's innervating the adipocytes via the beta-3 adrenergic receptor. And it is through these 2 autonomic pathways, the sympathetic and the parasympathetic pathways, that we end up being able to have something that looks like energy balance. And we'll go through each contribution briefly now. So a couple of years ago, my colleague Michelle Mita Snyder and I sat down and we constructed this model. And as far as I can see, based on the data that are out there in the world, this model still applies. So I'm sharing it with you. Notice the obesity sitting there in orange. You'll notice that obesity generates leptin. So fat cells make this hormone, the 17,000 Dalton hormone called leptin, which circulates in the bloodstream and gains access to the hypothalamus. And that leptin tells the brain not how fat you are, but how thin you are. So when leptin goes below a certain leptin threshold, which is genetically set for the most part, the brain sees starvation. So when there's obesity, then there's plenty of leptin, and the leptin should tell the brain that there's enough energy on board peripherally so that you don't have to, that you can engage in expensive metabolic processes such as puberty and pregnancy, that you can burn energy at a normal rate, and that you don't have to eat as much. So obesity should take care of itself because the leptin should negative feedback and keep you in yin-yang energy balance. The problem is it doesn't. The reason is because the leptin isn't transducing its signal. Now, it's not transducing its signal, and you can see the two X's there, through a process that we call leptin resistance. There's plenty of leptin, but the brain's not seeing it. And it turns out, through a lot of data I'm about to show you, that insulin that circulates blocker insulin both at the level of the hypothalamus, the VMH, thus leading to starvation, brain starvation, which is what obesity really is. And it also blocks leptin signaling at the level of the nucleus accumbens, the reward center, which would normally extinguish reward and make you then stop eating. So what that does is it stimulates further appetite. So you have more starvation, you have more appetitive reward because your insulin levels are high, because insulin's blocking leptin. So when your brain is starving, the sympathetic nervous system, via that beta-3 adrenergic receptor, reduces in activity, thus reducing how fast you burn energy, thus reducing energy expenditure because you're trying to conserve. That leads to a lowering of physical activity, which we call sloth. In addition, your vagus nerve goes into overdrive because you think you're starving, so you need to eat more, and the vagus nerve stimulates the pancreas to release extra insulin, so you end up generating a bigger insulin response than you even would have otherwise, driving even more of what you ate into fat cells and driving further obesity. In addition, the appetite increases, and that increases both carbohydrate, fat, and of course sugar, all of which will generate more insulin resistance. And that insulin resistance causes baseline hyperinsulinemia, which also blocks leptin. So what you can see is you end up with two negative feedback pathways that end up becoming positive feedback pathways because the leptin's not working. So through this effect on hyperinsulinemia, processed food, particularly sugar, as we'll talk about in a moment, generates hyperinsulinemia, therefore leptin resistance, therefore brain starvation, and therefore increased appetitive reward. Then throw the amygdala, which is the fear or the stress center of the brain, which generates cortisol. And cortisol both increases appetite directly through work done by several investigators over the years, Tatarani in particular, and also generates insulin resistance because of its effects on the liver and on the muscle. So you only make the hyperinsulinemia worse. So we called this model the limbic triangle, kind of like the Bermuda Triangle. Once you can't get out. Also, the importance of knowing where the problem is. There are three different reasons to eat: hunger, reward, and stress. And on any given patient, any one of those three or a combination thereof might be going on. And what we have learned and what we have practiced in our obesity clinic at UCSF over 15, 20 years is you have to know where the problem is in order to be able to treat it. Applying a blanket approach almost invariably does not work. You have to know if the problem is at the hypothalamus via starvation, and there's a way to know that by using an oral glucose tolerance test. You need to know whether the problem is at the ventral tegmental area and nucleus accumbens, that is reward, and you can find that out through a very detailed history, and you can even do an naltrexone challenge, which we have also done. Or the problem might be through stress, in which case the problem is going to be much harder to deal with because it's not really stress, it's response to stress. And that tends to be ingrained from a very early age, particularly due to adverse childhood experiences. And that's very difficult to break. So that's one of the reasons why this has been so difficult for people to tackle, is because in order to solve the obesity problem, you have to be able to have appropriate therapies for both starvation, reward, and stress. Okay, next slide. So let's talk about this leptin-insulin continuum and how it works. So here we have the nucleus accumbens receiving information from the hypothalamus. In the hypothalamus, all of those neurons have leptin receptors. They're also getting information from the dopamine cells from the ventral tegmental area. That's where the dopamine pericardia are. And there are leptin receptors there also. And then the prefrontal cortex, hippocampus, amygdala are ancillary to this basic reward pathway. So here's how it works. This is the easiest way to explain it. This is the paradox. What happens if you give a 5-year-old kid a cookie? Answer, they bounce off walls. And the reason they bounce off walls is because the cookie generates energy, the energy generates an insulin response, the insulin response generates adipose tissue deposition of energy, the adipose tissue deposition of energy generates a leptin response, the leptin goes up, goes to the hypothalamus, increases the sympathetic nervous system, SNA, sympathetic nervous system activity, thereby causing the fat cell then to give up the energy it just stored. And so again, you maintain a normal yin-yang energy balance. So increased insulin leads to fat cell deposition, which leads to leptin, which leads to increased energy expenditure. And this is how you maintain normal energy balance when you're 5 years old. Now, the paradox is, what if you give an obese 5-year-old kid a cookie instead? They're in the pantry looking for more cookies, right? There is no sympathetic response in an obese 5-year-old. And we know that because you can do this in rats. You can take out the hypothalamus and look for phosphostat-3, which is the downstream translational product of leptin binding to its receptor. And you can see that in the leptin-treated animal, the phosphostat-3 goes way up, as you can see in panel E and also in panel F. But if you block that leptin signaling using an antisense to the leptin receptor, as in this study, you'll notice that you don't get that same response. And what you get instead is an increase in the consumption of what particular foodstuff? Sugar. Not all foodstuffs, specifically sugar. Standard chow? No. Sugar? Yes. So sugar is the foodstuff that is preferred when you are blocking leptin. And we know that, and this is actually work from Sadaf Faruqi, who was part of that NeuroFast contingent. And you can see that these are leptin deficient patients. And you'll notice that they're in the leptin deficient state in the bottom left set of columns. Okay, they're secreting, they're releasing dopamine like nuts. But as soon as you give them leptin in the upper left, you'll notice that it goes back down to normal because you've basically given them the hormone that they are missing. And you can see that on the right side as well. In the fasted and the fed state, once they are leptin replete, things get better because they're missing, they don't have the leptin, their leptin level is 0, and now you are basically extinguishing that reward signal. When you look at the hypothalamus, turns out that every one of those leptin receptor positive neurons is also a tyrosine hydroxylase neuron, a neuron that makes dopamine. And it's also an insulin receptor positive neuron. So all of these neurons are coding for the insulin receptor, the leptin receptor, and dopamine, because this is a very tightly regulated system. Now, in the acute situation, insulin causes dopamine reuptake. So it's clearing dopamine from the synapse, as you can see here on the bottom. And insulin increases the degree of dopamine reuptake. In addition, in the acute situation, insulin blocks opioid effects on food intake. So there's DAMGO, which is a mu opioid receptor agonist, which causes food intake. And you'll notice that when you give insulin and DAMGO together in the right column, you basically obviate that stimulation, because insulin clears dopamine acutely. But when it's not acute, when it's chronic, when you have central nervous system insulin resistance due to chronic hyperinsulinemia, as you can see here, this is the brain insulin receptor knockout mouse of Ron Kahn from Joslin. You can see that the knockout mouse increases its white adipose tissue, its body weight, its plasma leptin, and the white adipose tissue. And the reason is because the increase in insulin is blocking leptin, generating increased food intake and increased body weight. So hyperinsulinemia is the bad guy in the story. How does this work? So this is a schematized version of a POMC neuron in the hypothalamus. And what you can see is there's an insulin receptor there in blue, and there's a leptin receptor there in pink. And there are bridges between the two receptors. IRS2, SH2B, and SOX3 are bridges between the two receptors that when insulin is occupying its receptor, it actually prevents leptin signal transduction. And in the process, it basically puts that leptin receptor positive neuron to sleep. And you can see that putting to sleep in this slide here. In the upper left corner, you have wild type neurons that are being stimulated by insulin, and you can see them going beep, 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 a lot faster once the leptin's been applied. But in the bottom right panel, those same wild type neurons, once you put insulin on them, look what happens to them. They go to bed. They stop firing. And when a leptin receptor positive neuron stops firing, that means it's not extinguishing that dopamine signal anymore. And so you're going to get continued food intake because of the high insulin. You can do this in cells that don't even have receptors. You can transduce the leptin receptor and the insulin receptor into cells called HEK293 cells, which normally don't have either. And in the process, you can turn a JAK2 positive signal into a nothing signal, into a nothing burger signal. You can reduce the signal by adding insulin because it binds to the receptor, blocking leptin signaling. So in every single one of these paradigms, insulin blocks leptin. And this is now pretty well delineated by many investigators, Marty Myers, Heike Munzberg, and many of Jens Bruning and several others. Clinically, we also have data that shows correlation in humans. So this is from Joan Hahn when she worked with Jack Yanofsky at the National Institute of Child Health and Human Development. What they did here was they took a bunch of obese kids, they drew their blood fasting in the morning, and then they let them loose at a metabolic buffet. And the metabolic buffet had little scales under each of the foods to be able to determine how many calories they were actually consuming. And it turned out that their energy intake was correlated with their degree of insulin resistance. So the more insulin resistant they were, the more hyperinsulinemic they were, the more food they ate, demonstrating that, again, insulin is blocking leptin. So we know that chronic hyperinsulinemia promotes obesity by driving energy into adipose tissue, interfering with leptin signal in the hypothalamus, which we call starvation, and interfering with leptin extinguishing of dopamine in the reward center, which we call addiction. So again, our limbic triangle. Hyperinsulinemia is responsible for leptin's inability to tell the brain that there's enough energy on board, and leptin's ability to stop the reward system from continuing to generate food intake. So those are the indirect effects. Now let's turn to the direct effects on the reward system. So now we're talking very specifically about the VTA and nucleus accumbens. Now, it is true that there are other neurotransmitters involved, like endogenous opioids, acetylcholine, cortisol, et cetera. And they're all equally important. I'm not going to discuss them today. We're just going to focus on dopamine for time. So here is that reward pathway, and I think Nicole showed it to you before. The cell bodies are in the ventral tegmental area, and they innervate the nucleus accumbens. When the VTA is stimulated, you get reward, because the signal is transduced at the level of the nucleus accumbens. And here would be, for instance, the effects of nicotine. So nicotine alters those dopamine neurons in the upper panel. You can see that the dopamine neuron starts firing when you add nicotine, because nicotine blocks GABA. That's its job as nicotinic acid, it blocks GABA. And at the nucleus accumbens, you will increase the firing rate of those neurons because you have blocked GABA, thereby increasing VTA activity and thereby increasing dopamine. You can do it with opioids. You can infuse morphine into the nucleus accumbens in rats, and you'll notice a dose-response increase in food intake. Thus, anything that stimulates that nucleus accumbens is going to generate reward and is going to generate food intake as a readout of that reward. And that is mediated through the D2 dopamine receptor. And again, I think Nicole showed you these data similar to this. Here we have a control brain. This is PET scanning using C11 raclopride, work from Nora Volkow and Jean-Jacques Long, showing that the control brain has lots of dopamine receptors, which you see in red. But notice the cocaine brain has way fewer receptors because they've been downregulated because of the chronic overstimulation by cocaine. That's on the left. Now look on the right, and you see a control brain and an obese brain. Well, what do you see? You see the same thing. You see the same downregulation of D2 dopamine receptors in the obese brain. And the question, of course, is it just obesity, or is it something specific that the obese people ate? That's where we're going. So as you can see, there is a decrease in dopamine receptors in humans in the left, in bonnet macaques in the center, and in rats on the right. It's across species. It's a standard paradigm. Ligands downregulate their own receptor. Dopamine downregulates its own receptor. And there are reasons why it does that, because dopamine is an excitatory neurotransmitter. So neurons like to be stimulated. That's why they have receptors. But neurons like to be tickled, not bludgeoned. Chronic overstimulation of any neuron leads to neuronal cell death, and that includes dopamine neurons. So the postsynaptic neuron wants to survive. It will downregulate its dopamine receptors to limit the gain, to limit the amplitude of the response. And that is the phenomenon which we call tolerance. So when you reduce dopamine D2 receptors, you're going to end up eating more to get less reward. And that has been shown in humans because there are people who have reduced dopamine receptors, and what they demonstrate is weight gain as opposed to those where the dopamine receptors are still at normal levels, who can either show weight stability or weight loss. And there's even an allelic variation, which was shown by Eric Stice at Oregon Health Sciences University, called the TAC1A allele, which reduces the number of dopamine receptors by 30%. So these people who are born with fewer dopamine receptors to begin with. And these people continue to increase their weight. And the reason is because they have to eat more to get the same reward effect. And you can see the genetics of this here on this slide. In the A1s are the ones in red. And you can see that they're not responding to dopamine like they should. And they're continuing to gain weight. You can see the slope of the line. So this leads us to the question of what is stimulating that dopamine and what is downregulating those D2 receptors. Now, obviously, this whole question of fast food, going back to the very first slide, is fast food addictive? Now, Michael Moss wrote this book, and you're probably all familiar with it, Salt, Sugar, Fat, How the Food Giants Hooked Us. This is incorrect. The reason it's incorrect is because he left out one major food group, caffeine. Okay, now it's right. Salt, sugar, fat, and caffeine. Now it's correct. So we're going to take each of these in turn. Let's start with salt. Is salt addictive? The data are relatively weak. In rodents, there is a dopamine reward signaling in response to salt, and you can see binging and cross-sensitization with amphetamines. That's true. However, in humans, we know that there is a lower threshold that's physiologically fixed. We know that people can go on the DASH diet and reduce their sodium intake voluntarily, that the higher levels are attributed to preferences, and they can be retrained relatively easily without any withdrawal symptoms. And we also have a model in pediatric endocrinology of salt-losing congenital adrenal hyperplasia. These are kids who do not make aldosterone, the salt-retaining hormone. So they are salt-losing constantly. They empty the salt shaker onto their French fries. They drink pickle juice out of the pickle jar because they have to replete the sodium that their kidneys are losing. But when we give them appropriate salt-retaining hormone in the form of Florinef, their salt consumption goes back down to normal. So when you fix their physiology, their salt preference improves. Thus, salt, not addictive. Let's go to the next one, fat. So is fat addictive? Well, Cinnabons are addictive, but is fat addictive? So rodents will binge, but they show no signs of dependence. In humans, binge foods are high in fat, like Nicole showed you, especially pizza and ice cream, but they're also high in carbs and sugar as well. In fact, foods that are high in fat only are not binge-worthy. And that's one of the reasons why the Atkins diet works. And no Atkins patient shows dependence. And we now have people on keto diets, which are basically fat, and you don't see any dependence in them. And it turns out energy density is a much stronger association with obesity and metabolic syndrome than just fat alone ever did. So fat, not addictive. All right, that leaves us with two. Caffeine, caffeine's a model drug of dependence. In fact, I'm surprised Nicole didn't spend any time talking about caffeine. Okay, and I will tell you, if you take my Starbucks away from me, I will kill you. All right, in humans, dependence has been shown in adults, in children. Everyone gets physiologic symptoms. 30% of people who consume caffeine meet the DSM criteria for dependence, including me. And physiologic addiction has been clearly established with lots of withdrawal symptoms, impaired task performance, fatigue, etc. Caffeine, model drug of addiction, no argument. That leaves us with number 4, sugar. Is sugar addictive? Well, remember what the NeuroFast group said, not addictive, and they specifically said so in their review of 2014.
I couldn't
I
get
want you
through
to
the
listen to
day
this.
without doing something to alter my consciousness.
And it started with heroin addiction.
It started with sugar.
Sugar.
Oh yeah, when I was 5, 6 years old, I was cramming sugar down my throat as fast as I could get it down. Sweets, sugar on bread and butter. I became addicted to sugar because it changed the way I felt.
So there's Eric Clapton talking about how he got into heroin. Okay, he started with sugar. He would argue sugar is a gateway drug. And I actually think that there's a lot of truth to that. Now, it is true that Eric Clapton is an N of 1, and an N of 1 is not science. But we have more than an N of 1 because we have this. Anybody know what this is? This is called sweeties. Okay, so some of you are in the United States. You might know this. I'm not sure if this exists in Europe or not. But what this is a super concentrated sucrose solution, a 24% sucrose solution that you dip the pacifier in and stick in the newborn boy's mouth before the circumcision. The Jews have wine and everyone else has sweeties. And the reason is because both of them will increase endogenous opioids to reduce pain. So we have the pathway, and we've known about it for years. In fact, National Geographic wrote about it. They said, sugar, why we can't resist it, talking about this phenomenon of sugar addiction. So is there really such a thing as sugar addiction? Well, we have to look for similarities to other drugs of dependence. So Nicole already told you about nicotine, morphine, amphetamine, cocaine, cannabis. The one I think is actually the most appropriate similarity is alcohol. And the reason is because sugar and alcohol are really the same thing, because after all, where do you get alcohol from? Fermentation of sugar, it's called wine. So for alcohol, the yeast does the first step of glycolysis. For sugar, we do our own first step. But after that, the mitochondria of your neurons and the mitochondria of your liver don't care. They don't care where it came from. And so they end up doing the same things. And so it shouldn't be too much of a stretch for people to understand that sugar and alcohol are virtually identically metabolized. And we have the neuroimaging data to support that. So this is work from Eric Stice. So what makes a milkshake so rewarding? So he took some normal weight young adult subjects and did fMRI studies with milkshakes where they would suck through their plastic tube different graded doses of fat versus sugar to make a customized milkshake. And then he scanned their nucleus accumbens to look at their dopamine release. And what he was able to show is that the fat in the milkshakes stimulated the somatosensory cortex, but it was only sugar that stimulated the nucleus accumbens. And adding more fat was not additive to the effect of sugar on the nucleus accumbens. So fat increases the salience of sugar, but it does not increase the reward itself. This has been now repeated by Wollnerhausen in Germany, where she did fMRI and showed that glucose stimulated other areas of the brain, such as the caudate, putamen, precuneus, and the lingual gyrus, but only fructose, the sweet molecule of sugar, stimulated the limbic system, the amygdala, hippocampus, parahippocampus, orbitofrontal cortex, and precentral gyrus. So these two molecules, glucose and fructose, are very, very different in terms of how your brain processes them and how it sees them and how it stimulates that reward pathway. This has also been looked at by Anya Jastreboff, my colleague at Yale University, working with Bob Sherwin and Rajita Sinha, showing that fructose specifically increases activity in the pleasure center, in the limbic system, and particularly in obese people. And the reason is because they already have drop down in their dopamine D2 receptors. Okay, so this is where Nicole and I are now, very similar in terms of what we're explaining to you. Once upon a time, in order to be addictive, prior to 2013, you needed two phenomena to occur, and those were tolerance and withdrawal. So tolerance more and more for less and less, and withdrawal, that is systemic symptoms resulting from abstinence. And so you needed both of those to be addictive. However, in 2013, in order to make gambling addictive, the American Psychiatric Association changed their criteria for the DSM-5. And what they said was, yes, tolerance and withdrawal still works, but now tolerance and dependence also work. And so they came up with these 9 criteria: craving, use resulting in failure to fulfill role obligations, recurrent use in physically hazardous situations, use despite social or interpersonal problems, taking the substance in larger amounts, attempts to quit or cut down, time spent recovering, interference with life activities, and use despite negative consequences. Well, all of those are met by sugar. So sugar does not demonstrate standard withdrawal, but it does demonstrate dependence. Tolerance and dependence, now considered addictive. So I agree with Nicole that sugar is in fact addictive, as is caffeine. So let's go back now to what NeuroFast told us. So these are the same slides I showed you before. In humans, there's no evidence that a specific food ingredient, or food additive causes a substance-based type of addiction. The only known exception is caffeine, is what they say. And then they say, within this context, we specifically point out that we do not consider alcohol beverages as food. Well, in fact, they're kind of right, because alcohol and caffeine are not food, they are food additives. They're things you add to food. So my question to you is sugar a food? Yes or no? Well, here we have on this slide the Food, Drug, and Cosmetics Act of 1938, the FDA's definition of food. And here's what they say. The term food means articles used for food and drink for man and other animals. Now, I don't know about in Europe, but in America, the first rule of vocabulary is you are not allowed to use the term in the definition. Take a look at that. The term food means articles used for food. How does that work? So forget that. So let's go to Webster, okay? Webster's dictionary. What it says is a material consisting essentially of protein, carbohydrate, and fat used in the body of an organism to sustain growth, repair, and vital processes, and to furnish energy. Well, sugar provides energy, but it only provides, and that's all it provides is energy. But according to Webster, that should make it a food, right? Because it furnishes energy. So my question to you now is, can you name an energy source that is not necessary for life, that there's no biochemical reaction in the body that requires it, that is not nutrition? There's no dietitian on the planet who would argue that this substance, this energy source, is nutrition, that when consumed in excess, it is toxic to cells, to organs, to humans, and causes death. And we love it anyway, and it's addictive. Anybody? How about alcohol? Alcohol is not necessary for life. 40% of America are teetotalers. They do not drink any of it, and they're still alive. There's no biochemical reaction that requires alcohol. Alcohol is not nutrition. There's no dietitian who will tell you alcohol is nutrition. When consumed in excess, it is toxic, and we love it anyway, and it's addictive. At least 20% of us do. So my argument is that sugar and alcohol are virtually identical because they're metabolized identically. They generate the same hedonic stimulus in the brain, and they're handled societally virtually identically as well. So aside from sugar, are there other energy sources that are not foods? And the answer is yeah, there are two: alcohol and trans fats. Both of those are energy sources, and both of those are not foods. Trans fats used to be a food, but it got declassified by the FDA in 2013. It is now a food additive. Neither alcohol nor trans fats are now considered generally recognized as safe. what we call the GRAS list. So this is a list of 10,000 items that the Food and Drug Administration allow the food industry to use carte blanche in any food, stating that they are not dangerous. Now, do you really think there are 10,000 things you can put in your body that won't kill you? Really? So the FDA took trans fats off the GRAS list. And it also took nitrates off the GRAS list because we figured out that nitrates are converted to nitrosoureas in the large intestine and cause colon cancer. So neither trans fats nor nitrates are now considered GRAS. So you can take things off the GRAS list. It's happened twice. So my question to you is, now that we know that sugar is really a food additive, not a food, could we get it reclassified as not GRAS? So, number one, being addictive does not get you off the GRAS list because caffeine is on the GRAS list and it is addictive. So GRAS is defined as generally recognized among experts qualified by scientific training and experience to evaluate its safety as having been adequately shown through scientific procedures to be safe under the conditions of its intended use. So it turns out GRAS is about toxicity, not addiction. But the problem with sugar is that the level of consumption that we are currently experiencing, 90 to 100 pounds per year, was never intended. Now, sugar's been known since 12,000 BCE. In India, they made a concoction out of sugarcane root that was an extract, which was known as khanda, Khanda, which is where our word candy comes from. So it's been around for a long time. And it's been on the FDA's GRAS list since the GRAS list's inception in 1958. The last time the FDA looked at this was 1986. And at that time, the average consumption was 51 grams a day, as opposed to today's 94 grams per day, almost double. So half as much. What they came to, the conclusion they came to back in 1986 was inconclusive. What I would argue is that now, because of the extra increased consumption, if they did those studies today, they would find that this was by no means inconclusive, that in fact, sugar in excess is toxic. And we have said so on numerous occasions, and I'm sure you've heard that. This is Gary Taubes' article about our research at UCSF on the left, Is Sugar Toxic? And our comment in Nature, The Toxic Truth About Sugar. So I'm going to close with this notion. On the left, we have no argument about the fact that this is both toxic and addictive, and we regulate them. So this is my question to you. Is this true? And I would argue absolutely yes. And we even have empiric data that supports this. So here's what's happened to our food as we've been asleep at the switch. 1982 to 2012. Meat's down 10% because we were all told to go low fat. Fruits and vegetables exactly the same. Notice 14.5, 14.6. No change. The reason is because it's not about the fruits and the vegetables. It never was. Okay. Now, it is true we do not eat enough fruits and vegetables, but we never did. Ain't new. And we didn't have this problem in 1982, but we sure as hell have it now. Now, grains and baked goods, up 1%, and that's important because grains and baked goods, processed carbohydrate, that's glucose, and glucose means insulin, and insulin means weight gain, and weight gain means insulin resistance, and insulin resistance drives this. So no argument, processed carbohydrate is a bad guy in the story. Agreed. Dairy products down 2.5% because we're all now lactose intolerant. And the most important one, processed foods and sweets, 11.6 in 1982, 22.9 in 2012, a doubling in the span of 30 years. And that's where the action really is. Because of the 600,000 items in the American food supply, 74% of them are spiked with added sugar. And 56% of the sugar is in ultra-processed foods. So again, it is, Nicole told you about food processing being the important thing. I couldn't agree more. In fact, I am writing a book now on processed food that will demonstrate it is the food processing that makes it dangerous. So in summary, It's not about obesity. Food addiction is a misnomer, okay, because it's really sugar addiction. So in that respect, NeuroFast is right. They're just wrong about the fact that it's not eating addiction. The only items in junk food that are addictive are sugar and caffeine, but they're not foods, they're food additives. Fat and salt both increase the salience of food, especially of sugar, but they themselves are not addictive. They're habituating, but not addictive. Just because something has calories doesn't make it a food, because it can be a food additive like alcohol and trans fats. So the only way to fix this problem is through getting it off the GRAS list. Now we've done that twice with trans fats and nitrates. The Center for Science of the Public Interest is currently exploring ways to get sugar off the GRAS list at my suggestion many years ago, and hopefully we'll be able to work together on that. GRAS focuses on toxicity, not addiction, but fructose is both, and sugar is toxic in current doses, which were never intended. With that, I'm going to close. Thank my collaborators at UCSF, at Touro University, at San Francisco General, at the UCSF Institute for Health Policy Studies, Nicole at Columbia. And with that, I'll be happy to entertain any of your questions. Thank you for your attention.
Thank you, Robert Lustig. Wow, this is quite something. When I've had the chance of listening to you, I need to sit down and go back and forth with my brain, and so people will be able to get recordings of this. Just ask for it. And we were kind of over the time, but if we can have like 2 questions or so. So we have. Can you see, Robert, the questions? Questions and answer. There's one there. Is fructose? If fructose is the problem, what about fruit? That's one question here. You want to answer that one? You need to unmute. You want me to? Yeah. I'll unmute you. No. You can't unmute you. Why is that? Oh, there you go.
Okay, good. So what about fruit? The answer is fruit has fiber. Mm-hmm. Fiber limits fructose absorption because fiber forms a gel on the inside of the stomach and duodenum, preventing early absorption of fructose so it doesn't reach the liver. So when you consume fructose as a soft drink, you are getting 100% absorption. When you consume fructose in fruit, first of all, you're getting a lot less. And second of all, you are not absorbing about 35% of the fructose. So you are actually limiting your liver's exposure, and therefore you are limiting the amount that ends up passing the liver because of the hepatic first pass extraction is not perfect. And so therefore, less fructose is reaching the brain. So it is true that the molecule in fruit is the same molecule as the molecule in a soft drink, but it doesn't do nearly the damage because it doesn't get anywhere. It doesn't get past the intestine, it doesn't get past the liver, and it doesn't get to the brain. So I am not particularly worried about the sugar in fruit, as long as that fruit has not been processed. As long as you haven't stuck the fruit in a Vitamix, as long as you haven't turned it into fruit juice, I think fruit's fine. And after all, fruit has lots of antioxidants, polyphenols, flavonoids, lots of other vitamins that are appropriate and necessary for good metabolic health. So fruit is good, juice is bad. So the next question is, would the complete absenteeism from added sugar during an entire lifespan be advice you would give to a person? And the answer is absolutely, if you could do it. And I can prove that because there is a disorder, a medical disorder, known as hereditary fructose intolerance, HFI. It is a defect in the enzyme in the liver called fructose 1,6-phosphate aldolase. And you need this enzyme in order to be able to break down fructose. If you are missing this enzyme, what happens is you tank your blood glucose down to 5 the first time you get orange juice from your mother when you're 6 months old. You end up seizing, you end up showing up in the emergency room comatose. They end up admitting you to the intensive care unit, realizing you're hypoglycemic and you're ketotic. You have ketosis and hypoglycemia. So they end up doing a liver biopsy on you, and they find out you have hereditary fructose intolerance. Those people who survive that event, they have to go on a fructose-free diet for the rest of their lives. Because anytime they get fructose, they get hypoglycemic. And no one's ever figured out a way to be able to get them to. They are on a sugar-free diet. I know one particular person who has this because she was on our Eat Real board for many years. And her sister, who was older than her, ended up mentally retarded. They saw that. They had diagnosed her after the fact, but they knew it for my colleague. And so she was on a fructose-free diet her entire life. And there is a registry of these patients out of UC Berkeley, and they are the healthiest people on the planet. So yes, it is very appropriate to abstain from added sugar your entire life, and you will be a lot healthier and a lot happier over the course of time. Of course, the problem is that since there's sugar in everything, it's pretty hard to do, especially with our current food supply. Let's do the last question from Dr. Younglove, who is on my LinkedIn frequently. And she says, I talk about sugar and starch addiction, processed food addiction all the time, which I totally believe. My patient, I think my patients do go through withdrawal when I take their sugars and simple starches. In fact, they do go through withdrawal almost for sure because they're consuming a lot of sugared beverages. And so I think that they are in caffeine withdrawal. Mm-hmm. Now, it's not been shown that sugar alone is withdrawal through the same mechanisms, but since a lot of sugar addicts are getting their sugar through soft drinks because it's the fastest and most convenient method for being able to ply themselves with it, they're also caffeine addicted. And so they may get withdrawal symptoms from the caffeine abstention, not from the sugar abstention. So there's no question sugar causes dependence. It may cause withdrawal in some patients too, but the caffeine withdrawal is like the likely culprit for why those patients seem so sick. Do you have support from your medical colleagues? And the answer is some. Not everybody, but some. More and more, I'm happy to say, but it's definitely been a long road because there are a lot of people who are still on the calorie bandwagon and haven't recognized that, you know, different foodstuffs cause different diseases and have to be dealt with through different dietary changes. This is an ongoing problem. What I would say is we now have sugar taxes in 28 countries around the world, so somebody's getting the message. So with that, I'll be happy to close and thank you all for your attention and your questions.
Thank you, Dr. Robert Lustig, and enjoy Paris, France.
Merci bien.
Talk to you soon.
Okay, à bientôt.
Arriba. Okay, I am good. So if you would stop sharing now, then we can get to Vera Tarman, who is next in line.
How do I stop sharing? I gotta figure out.
Oh, I think I can.
If you can stop, it'd be better because I can't seem to find it. Oh, there it is. Stop share. Okay. Bye-bye, everyone.
Bye-bye. Okay. Okay. Thank you, everybody, for this. We're on, a bit over time, and I am going to get Vera Tarman here, promote to panelist. There we go, Vera. And now you do need to unmute and get your video on. if you would please. Can you do that? Okay, there you go. I'm seeing you now.
Yeah, you invited, you can hear me?
Yes, I can.
You invited me, so I have to move my, I have multiple screens here.
Right.
Ready.
And for some reason, Nicole and Teresa came in and through the invitation, panelist invitation, but you were like, you were in the viewer's view. So I needed to get you from there.
Yes, okay.
So, okay, so I just want to introduce Dr. Vera Tarman, a dear colleague and incredible asset to food addiction and the addiction field in general. And I give the word to you, Vera. My apologies for going over time, but we kind of had a bumpy start with Dr. Lustig, and we'll see how the time goes, and you have one after you, which is Teresa. So we'll try to divide the time between you, brotherly. Go ahead, Vera.
Thank you very much, Esther, and thank you so much, Dr. Lustig. Wow, that was a great, my talk is going to be a nice segue from yours. I'm very happy to share my time, so that's not going to be a problem. So I'm going to do the screen share now, and see, hopefully that will work. Okay. Share. So I think that's pretty good, eh?
I got it, and if you want to keep it so, but you can also do like a one slide.
I don't want to, you know, I prefer if we can do this, it's better for me, because otherwise, because of my screen share, it messes me up.
No problem. You go ahead.
I think this is big enough.
Yes.
Okay, good. So as Esther said, I'm Dr. Vera Tarman. I have been working in the field of food addiction for a number of years now. I have a book called Food Junkies, Recovery from Food Addiction, and work in our Renaissance Center in Canada on a food addiction program. But my real history is as a clinician in addiction. And so Dr. Lustig did a great talk on hormones, and you know, he always throws in a bit of the policy and politics, which is what I love about his work. My talk today is going to be more from a clinician. I am research informed, certainly, but that's not my focus today. My focus is basically to talk from a clinician point of view, and the talk is about the medications that exist for obesity. And I mean, it's called No Silver Bullet because there is no great answer. But anybody who is in the field wanting to be a practitioner of some sort really needs to know what meds are out there that might, that promise to be a silver bullet, and that also might be a problem for weight loss and also for addiction. And you know, these medications are premised both on the hormonal and the addictive pathways, which is what Dr. Lustig just talked about. So that's really good. I'm going to just jump to this first slide to say that the whole concept about pharmacotherapy, which is what I want to talk about, is to give a context to that. In the past, we have dealt with we have not talked about food addiction because that's the new, I mean, we're the ones that are pushing that concept, and it still needs to be acknowledged in the medical community. There are rare people who are doing that still. So the whole idea about diet and food has been mainly about not addiction, but weight loss. And over the years, not only do most of us who have tried to do this on our own realize, yes, you can lose weight, but how do you keep it off? So and clinicians who work with patients, like family doctors and endocrinologists, have developed almost a despairing attitude of, you know, what's the point? Because we, you know, have people lose weight only to regain it. So in today's mindset, the pushing of food is less, and I think it's going to become less of an, unless we, food addiction advocates, can get our names stamped out there. We're going to see less and less of that, because what I'm seeing is a sort of the concept of fat shaming. And if I tell somebody that they really should lose weight, and we know that people lose weight and then regain it, that I'm just really instilling potentially some level of disappointment, on like future disappointment and shame. So better that I don't focus too much on that. So what does that leave us? And I'm talking about a medical approach here. That leaves us with, I don't know why that's making noise, sorry. That leaves us with pharmacotherapy and surgery. And in the American-Canadian framework, the bariatric surgeon preceded the bariatric clinician. I mean, it was food and the failure of that. And so what did the patient do? They would go to their doctor, who, once they realized, well, the diet's not going to work, there were really no medications for the longest time. So it was surgery. And so the whole emphasis, even though it's at the top of the line here, even today, if you look at the Canadian Family Practice Journal and probably the American Medical Society or the AMA Journal, you'll see that surgery is considered first option for obesity. And I'm just going to show you here that that we've got lots of money, lots of attention. This is the medical focus on the various bariatric surgeries, and here are the 4 of them. I'm only giving you all this information because it's a background, and I will certainly, there's enough time to do this. The adjustable gastric band, the Roux-en-Y, the gastric sleeve, and the duodenal switch, all which essentially do one of 2 things or both things. They obstruct food intake by making the stomach simply smaller. You can't fit in as much, or they do that and avoid the absorption of specific nutrients that presumably in the calorie in, calorie out model will mean that you're not taking in as many calories. There's, in that research, there's claims to make more, but this is still very new, and in a way we're doing research while we're doing the procedures. There's not that much research ahead of time. Anyway, I'm going to just end talking about bariatric surgery only by saying that we know that it's first-line therapy for the most part. There are a lot of side effects that we can talk about, which we won't. And it's very expensive, and so therefore it's not that available. So I said that there's the bariatric surgeon. That was the first sort of medical acknowledgement. Even the concept of bariatric work started with the surgery. But there were a number of people who said, I want to work with, the field of obesity, but I'm not a surgeon. I'm going to, basically work in the clinic, deal with all the consequences of obesity. And then we have this new breed of animal called the bariatric clinician. And now there's a new diploma, a clinical medical diploma for obesity that that I think has come out in the last 5, maybe 10 years tops. And so we're going to see more and more of these bariatric clinicians. Well, they're not doing the surgery. And although they're talking about diet, that's not really so much the focus. What does that leave us with on this pyramid? It leaves us with the pharmacotherapy. Well, what kind of pharmacotherapy have we got? I'm going to give you our categories here. So the categories of pharmacotherapy can be nicely organized into these 4 categories. The first one being the amphetamines, and they are the oldest, probably the most effective in terms of weight loss. This has got nothing to do with addiction. Actually, most of these have little to do with addiction. To some degree, the anti-craving one does, but we're talking weight loss here. So obesity medication is primarily about weight loss, with some nod to addiction, but not very much. So amphetamines is the first one so I'm going to address them. So if you need to know anything about medication in the field of obesity, it's got to be the amphetamines. Been around since the 1950s. Dexedrine was the first one here, and was prescribed like, I want to say like candy. Not surprisingly, along the same time as we were prescribing Xanax, which is the drug to mitigate the effects of amphetamines. So what does an amphetamine do? It basically stimulates the sympathetic nervous system, or the stress response. It makes us hyper. It stimulates the adrenaline response. And so I am, part of the adrenaline response is that I don't want to eat. My mouth is dry and I don't want to eat. And I'm ready to fight or run. And that means that it's called an appetite suppressant, because it suppresses appetite, and it increases the body's metabolism. So presumably you might lose some weight in that way, and that's how that works. Because it sits on the adrenaline pathway and causes essentially a stress response. I mean, adrenaline is the acute form of stress, but the long-term form of hormone for stress is cortisol, and cortisol has many, many, many negative side effects. So it's really not a good long-term approach. In fact, it can actually promote weight gain in the long term. Mainly, one of the reasons why we stopped using amphetamines overtly for weight loss, and I'm going to say overtly, is because it caused a lot of other symptoms, not surprising, like anxiety, insomnia, just agitation, and even for some people, paranoia. So it's really not a good long-term solution. And like any medication, once you stop using it, any of the efficacy is gone and people would gain weight again. So now, from a medical point of view, it's frowned upon to use a Dexedrine or Ritalin or Concerta or any of the stimulants for weight loss and Vyvanse. Before I speak about Vyvanse, I do want to say that, of course, people have been smoking tobacco for a similar reason. It does have some weight loss effect because of the appetite suppressant effect, and also just chemically, so that if you quit smoking, I think the estimated just metabolically weight gain that's expected, it can be up to 10 pounds. People have, of course, under the radar been using for many years cocaine and crystal meth. I work in the addiction field, and I know that many people, the ongoing, once they've realized this is a devastating drug, struggle not because of the addictive nature of these drugs, which they are, but also because of the weight gain that happens when you stop taking this very powerful appetite suppressant. There is a drug, ephedrine, which is actually a precursor for crystal meth, that you could buy in the herbal market, that had a similar effect, an appetite suppressant effect, and basically an amphetamine effect, but it's been taken off the market. Apparently you can get it in some places, but it's not allowed anymore. So we have the overt use of amphetamines that were used for weight loss since the 1950s, when they came onto the market, until probably the 1990s, when it was starting to be recognized as this is not really the benefits, or the consequences outweigh the benefits. And so you really have to have a good case for using an amphetamine medication on a long-term basis. And since we really didn't have anything else at that point, that would be where the surgery would come in. Now, in the last 15 years, there's a new drug that's come on the scene, Vyvanse, which is a stimulant, and I think provides the very same mechanism of action, but it has been marketed in a very clever way, alongside, in terms of the medical approach to obesity, where there's been a recognition that, yes, there is a psychological component to this, because nobody's yet really, food addiction has not been widely embraced, as Dr. Lustig has so aptly explained from his point of view. The only real psychological dimension that people can look at is eating disorders. And so if you speak to a sort of standard bariatric clinician, not somebody who's willing to kind of look out, into the, I'll say conservative, I'll just say the conservative bariatric clinician, they might say, well, I'm dealing with obesity and I might be dealing with an eating disorder, but the food addiction is not really on the plate, as it were. So if we look at binge eating disorder as a potential way to deal with an eating disorder, that's really where the focus has been. So if the patient is sitting in front of you, they're obese and they're saying, I can't go on a diet, and doctor's saying, I know that you can't, this has been the problem. Well, maybe you have an eating disorder, and we'll send you down the hallway to the psychologists who deal with that. And most likely you'll get pegged with the diagnosis of binge eating disorder. You might also get pegged with bulimia alternatively, but in any case, the company that makes Vyvanse has been very intelligent in that this is a stimulant that was made initially for attention deficit disorder and has nothing to do with food, at least when it was made, but as an off-label use, which then became now their label use as well. They said, hey, this is can also be targeted and marketed for binge eating disorder. And I think the premise behind that is that the impulse control in the frontal lobe, which is how Vyvanse works for attention deficit, is the same place as the impulse control loss that happens with binge eating disorder. And so we're going to the same area, doing the same thing. And I guess you could say that binge eating disorder is kind of like attention deficit. They're both impulse control issues that Vyvanse can help. So that's how they've marketed it. And I could not write a script with medical assurance if I said, I'm going to write you this script for Vyvanse so that you, because it's a stimulant, so that you will have an appetite suppression because it's a stimulant like Dexedrine or Ritalin. But I can write it if I call you as having a binge eating disorder. So consequently, I have it in orange because it's probably one of the most commonly prescribed drugs for the patients that we see. So because it's an appetite suppressant, but it has all the consequences that we had before, and it's kind of nosed its way back, but with this different indication. But as soon as the person stops using the drug, because they're so anxious or find that the effect of it has been tolerated to the point where they need more or something like that, maybe they decide to go off of it and now they're going to gain their weight back. So that's Vyvanse, very common. And the other negative thing about that, besides the fact that it only works while you're taking it, is it does take away from, if you are suffering from a food addiction and you are at an end stage, I mean, those of us in the field will acknowledge that there are early stage, middle stage, end stage. And perhaps in the early and middle stages, you can tolerate a drug like Vyvanse. But if you're at an end stage and it's an addiction and the clinician is willing to acknowledge, like I do in my work, this is an addiction and has an addiction syndrome, a whole plethora of symptoms outside of just the food. My worry is that this is actually a gateway to other drugs because they're at a certain point in the brain, as Dr. Lustig showed, it's all in the same pathways. It's the cocaine, it's the food, it's all going to the same pathways. And whether it's Vyvanse or tobacco or whatever it is, you're potentially opening the gates up for addiction. So I worry about that in that context. Anyway, that's a very common drug. And I think as food addiction clinicians, we should be wary of it, but maybe in early stages it's useful. If somebody's on it, I would warn them if they wanted to eventually get off to beware and to be extra cautious of their food and what they're eating that might be potentially addictive, because they may find that once that appetite suppressant kind of protective effect is gone, that suddenly their appetite for foods that they might have been able to get away with because there's a slight craving sort of bounce into their face. Okay, so that's amphetamines. Now I'm going to talk about the psychotropic drugs. And these are the, like basically, we could say the antidepressants. Oh, yes, I talked about that. Okay. The psychotropics. Early on, Prozac being probably the first drug in the early 90s, late 80s, people kind of discovered Prozac being a selective serotonin reuptake inhibitor drug that's supposed to help for mood enhancement and anxiety. People discovered, hey, you know, this actually seems to help people not eat so much. So I think that the idea was early days, before we had other drugs, that if you took a drug like Prozac, which existed then, Celux is an SSRI, but now a much more modern current one, that there was some element of, you know, treating self-medicated eating. You know, you're depressed, you eat, because we know that it has a mood-altering effect, and so, you know, this is working. And probably alongside the amphetamines, this one was used, the two of them were used a lot. Now that we have more drugs, more will fit into the drug. I mean, there's many SSRIs, probably 15 or so. I've just written the sort of two well-known ones. There is the selective the SNRIs that have this is focused on serotonin. This one has a norepinephrine effect as well, which is basically the adrenaline, the hormone of adrenaline in the brain. And so the idea here is with SSRIs, you get a little, this is the theory, the pharmaceutical theory, that you get a boost of serotonin. In other words, a boost of feeling safe and easy and comfortable. Here you get that same boost, plus you get a little bit boost of adrenaline, which has that appetite suppressant effect. So it's a sort of the best of both worlds. And Effexor is probably the most common one that's used for that. But there are a number of other ones that in the last 20 or 30 years have been proposed and then taken off the market because of their negative side effects. But they have that same idea of there's an element of treating the self-medicated eating because it's sort of capturing the serotonin and the norepinephrine pathways and giving a little bit of a boost. Treating the self-medicated eating and seemingly either, depending on what drug literature that you read, suppresses appetite or promotes satiety, which are actually two separate things as far as I'm concerned. But anyway, and so that seems to help. However, there's been some problems with those. Maybe I'll just, before I just want to mention these other two. Again, the orange means these are the most common ones. Effexor is very common. Wellbutrin, not an SNRI. It's just considered an atypical antidepressant that has a either weight neutral or possibly weight suppressing effect. And so even though it's an antidepressant, we're not really sure how it works. It seems to be helpful for some people, so it's used too. It doesn't seem to promote weight gain, although Prozac is pretty good for not promoting weight gain. I think it's considered weight neutral. There are some drugs that do cause weight gain. A classic one would be Paxil. Anyway, Wellbutrin, weight neutral, or maybe even some minor weight loss. And so that's on this list as well. And it might be used as while you're depressed, but let's do a double hitter. Let's do the weight as well while we're at it, or at least not make the weight more. Topiramate is considered a mood stabilizer. It's actually an anti-epileptic drug. There's no reason why it should be on here, other than that when they used it to see if we could use it for mood stabilization, there was enough clinical evidence that, oh, this seems to actually promote weight neutral or weight loss, because it seemed to do something with appetite. It seemed to suppress appetite, but people don't really know why. So that's why these are on here. They are either weight neutral or weight help with weight. So getting to here. If you were talking about the weight, it might be only about 10%. And 10%, if you're 300 pounds, well, we're looking at 30 or 40 pounds, not bad. But, you know, I don't think it's hugely significant. But I'm coming from, now it depends on if you're a clinician who's used to people losing weight and gaining weight, and ultimately they lose weight only to gain weight. That's a pretty good result. So I have to give that, I do have to give credit to that. But frankly, I'm coming from a background where I see people, when they do things like what Dr. Lustig said, stop the sugar and processed food, they lose much more than 10%. They lose 40%, 50%, and keep it off. This kind of finding is not that significant. Depends on where you're coming from. Anyway, these drugs can cause anxiety or an atypical mood reaction. For example, Wellbutrin, I've seen people act very oddly on this. I mean, we know that antidepressants, this is the reason why we don't just let them be over-the-counter drugs. There is a small group of people that have an atypical reaction, basically, and the opposite reaction, where they might actually get suicidal or paranoid or more psychiatrically disturbed than before they took the medication. Wellbutrin is actually higher on the list, with my experience with that, than others. So it's you know, you are playing with the potential for having an atypical mood reaction and anxiety. Some drugs like Paxil, it depends on the antidepressant. I know that when I was studying family medicine, we were taught that the first category of antidepressants, that was Paxil, Prozac, Luvox, and Zoloft, were more or less all the same, but had slightly different side effects. And we treated the drug based on the side effects. Did you want the person to be a little more sedated because they were so anxious? Or did you want to kind of wake them up because their depression was very lethargic? And it was basically based on that. So depending on what you're taking, you can have these as symptoms. And similarly, there might be weight suppression, but there may also be weight increase. And I see more often than I see not, this is as a clinician speaking, that there's more increase in weight and appetite. And when it's that kind of appetite increase, we're not talking about the desire to eat more Brussels sprouts. We're talking about the desire to eat more carbs, more sugar. It's well known that it can suppress libido. And then these two here, pulmonary hypertension and heart valve defect, have been associated with, I'm just going to go back, to these drugs which are now off market, also SNRIs, like fenfluramine, also known as Ponderax, or Redux, or Meridia, they were considered the most effective of all of these psychotropics, but they were associated with these problems with pulmonary hypertension and heart valve defect. And pulmonary hypertension is something that you know, you can die from. It's, you know, it's a lung condition that is basically has a fatality associated with it. And when when a physician is prescribing a medication, they always have to weigh the costs and benefits, and the costs of that were not worthy of the benefits of this. So they were taken off the market, and we were left with these, which did not seem to have the same kind of effect. So that's the psychotropics that are we're talking about. Now I want to move to the craving blockers. We have, the orange is the one that's prescribed the most. Like, if you want to make this a really simple talk, just remember what I've made in orange. Revia or naltrexone is probably only medication that actually has a nod to addiction. So Dr. Lustig had very nicely described how about the nucleus accumbens and dopamine, and there's an endorphin effect as well with sugar. Sugar, like alcohol, gets all of our neurochemicals, gives them all a boost of a sort. So any drug that suppresses the firing or the activation of one of these parts of the reward pathway of the brain may have an effect. So naltrexone, which is classically used in a different form, like Narcan, for opiate overdose, or alcohol, because alcohol and opiates are used, if not completely, partially, the endorphin receptor. It's also used for sugar for the very same reason. It's really an example of how these drugs, it's all the same pathways. It's really what I'm trying to say. So Revia is used. I don't actually know how successful it is, but when you've got not much else to offer, it's something to offer. Rimonabant is a drug that's off the market. It is a, here we have it, Revia is an opiate blocker. It's an endocannabinoid blocker with the belief, endocannabinoids, we have natural endocannabinoids. Smoking marijuana is a way to activate those. And we all know, for those of us who have smoked in the past, know that it creates the munchies, it creates hunger, it creates the pleasurable feeling of eating. And rimonabant was a way to suppress that. And, that's not small potatoes, as it were, because much of the research that we're looking at now with opiates, we're starting to question, was it actually the endocannabinoid connection? There is a connection between the two of them, that in fact, that we should be focusing more on suppressing the endocannabinoid system more than the opiate system. Anyway, that's just something of interest. However, it got stopped. It's off-label as well. I think it was taken off the market about in the late 1990s. I'm only mentioning it because it's off-label. You might think, why bother knowing about it? Because it was considered quite effective in reducing appetite. So if you don't eat the food, and we know when you have the munchies, it's not Brussels sprouts you want to eat. It's the processed foods that a person reaches for first. But it was discovered that there was a high association with suicidality and depression. And my guess is that if you suppress with these drugs, the opiates and the endocannabinoids, you're suppressing your own natural ones as well. And we need our own natural endocannabinoids and opiate system working to have a sense of well-being in life. And really, that statement, we need our own natural system, is the fundamental core of my interest in this whole work, because I would much prefer, rather than using a drug to suppress these, to find out what it is that activates them in a heightened way, get rid of that, and then we get the best of both worlds. We recover our natural system, which is this, without medications. Anyway, so that's back here. It's been taken off the market, even though it was quite effective. We have these other drugs that are thrown around. They're thrown around with food, baclofen, camprol, gabapentin. They're thrown around as craving reduction meds for cocaine, for alcohol, more and more. Like in the addiction field, I'd say that these are the, especially baclofen and gabapentin and versions of that, are thrown around quite a lot now as, can we reduce cravings for drugs of abuse by using these drugs? So baclofen is actually a muscle relaxant. I don't know how they got the idea to think that this might have something to do with craving reduction, but early on, maybe 15 years ago, it started with cocaine. And like I said, now it's being used more. But anyway, it's now being used off-label, but being researched, so presumably one day maybe label use of cravings. But it doesn't really make sense to me physiologically, because it's a muscle relaxant. It's the drug that, it's actually an antispasmodic. So it's the kind of drug that somebody who might have multiple sclerosis and has muscle rigidity, it would help them reduce that. People with back pain often take it. Gabapentin, again, who knows? There's some belief that all of these drugs have some focus on the GABA receptor. They enhance the GABA receptor, which is the neurochemical that's ubiquitous in the brain and in the body for basically relaxing or slowing down a metabolic process. So basically, it slows down the brain. It's like when you have a drink and you just relax. When you take a Valium, which is a GABA agonist, you just relax. Although baclofen and gabapentin are not Valium and alcohol, they hover around the same neurochemistry, and we're not really sure how they work. Probably but they do. Gabapentin was actually first an anti-seizure medication, and now is used for pain, usually if it's a spasmodic type of pain, mood stabilization, and now craving reduction. Is it effective? That's not been my experience. Again, because I'm coming from a very positive background of seeing what is effective and really works. But if you've got nothing else other than diets that just don't work because you're still trying to eat moderate sugar, these probably help somewhat. That'll be my statement there. Okay. So that's the craving reduction meds. We have some concern about them because, as I said a few minutes ago, if you suppress your own, if you're suppressing the effect of them, you're suppressing your own natural endorphin endocannabinoid system, and you may be left with a flatlining, like nothing makes me excited, nothing makes me interested. So hence leading to a sense of hopelessness, depression, suicide. And there appears to be some worry about liver disease. Okay, so that's the craving blockers. I want to talk about the fat blockers. Not used that much anymore, but it's a classic one that you should know about if you're in the field. Xenocal or orlistat was a medication that was prescribed maybe 15 years ago, stopped when they realized that they didn't like the side effects. But what it did was you eat the food, take Xenocal or orlistat, and it blocks the absorption of the fat in the small intestine so that you don't absorb it, therefore you don't gain weight from fat. Of course, now we're realizing fat has very little to do with weight gain. So, you know, why would we even use this unless you're following that model? And consequently, there wasn't very much weight loss. But the main thing that people didn't like is that it caused, cosmetically, if you know, where does that fat go if you're not digesting it? It goes into the stool, so you get this slippery yellow stuff that comes out sometimes not even when you know it, and it's just cosmetically not very appealing. And it's a dose effect. The more you take, the more that happens. And because there are so many vitamins that are fat soluble, if they require fat to be absorbed, you put yourself at the risk of vitamin deficiencies. So not a popular drug now, but one that a person should know about. Then we have, if we look at our categories of drugs, I just want to show you where we are here. I've touched on the amphetamine, the psychotropic, the anti-craving. Now I want to look at the hormone-based drugs. This is probably where there is the most excitement, the most interest, and probably where the more research and more drugs that come down the pipeline we'll see. Saxenda is probably the best known of this sort of category of drugs. Dr. Lustig talks very nicely in one of his books about leptin and you know, the promise of leptin and you know, how the failed promise. That, you know, if leptin is the hormone of appetite satiety, then if we upped the leptin, then the person would be satisfied and wouldn't need to eat, and therefore that calorie in, calorie out model. But we know that that doesn't work anyway. But what we've discovered is that you can have a leptin resistance, and so taking that drug doesn't really help unless you are truly leptin resistant. Pardon me, have an increase of leptin. No, you have an actual condition that has nothing to do with the diet, and that's very low. So leptin was considered a promising area that has now been sort of neglected. And no, it's not going to be useful. It's not a fruitful thing to go forward on. Metformin is let me see here now. So there was the leptin thing, significant leptin insufficiency. It was injectable. Anyway, not effective for leptin resistance. And we know that most obesity is caused by leptin resistance, not leptin insufficiency. Metformin is a medication for diabetes, which improves insulin resistance. And Dr. Lustig said very nicely, that's the whole problem. We have this hyperinsulinemia thanks to our diet, and then you become resistant, so you can't use the insulin, and therefore you become diabetic because the sugar stays in the blood and doesn't go into the brain and muscles and wherever it's necessary to go. So the thought was, well, maybe we could use that somehow to our advantage, but you really run the risk of hypoglycemia. It was actually a drug that in the family medical world, we were encouraged not to use in the late 90s. But then when we discovered that unlike insulin, where if you're a diabetic and you start using, and you haven't been using insulin because you didn't know you were diabetic, you start using insulin, profound weight gain. Because insulin, you're giving yourself insulin and it creates weight gain. It diverts the sugar into the fat cells. Well, we found that with metformin that didn't happen quite as much, so it's gained a lot more favor in the last number of years, and is now used almost first line as oral medication for diabetes. Thyroid medication is, oh, wait a second, here's some more to say. Yeah, so, no, that's good enough. Thyroid medication is basically the thyroid is the hormone that governs the body metabolism, and it is primarily used when a person becomes hypothyroid. Their thyroid is no longer working, and so then when it's no longer working, they become slower, more likely to develop weight gain, become depressed. Memory goes down, cognition is not as good. I mean, it's a condition that's very common actually with postmenopausal women, but it happens across the board. Some psychiatric medication cause it. It just seems there's a number of conditions that create this. Anyway, it's always worth checking when you have somebody in front of you that is resistant to weight loss, especially if they're eating the proper foods, to say you better get your thyroid checked. But it would be a useful drug to take if that's the reason for the weight loss, or weight gain rather. But there are some more unscrupulous clinicians who might say, well, maybe we can kind of, even though your thyroid is fine, give you some to kind of enhance the body metabolism. It's kind of like using adrenaline in a way. But that's not used that much. But anyway, just to be aware of that. I think the biggest and most important drug that's on the market that has the most buzz right now is Saxenda, which is a hormone-based drug that addresses a lot of what Dr. Lustig was talking about, the leptin and insulin pathways, moderates them. It promises, it promises to enhance the liver can make its own sugar through a process of gluconeogenesis using a hormone called glucagon. And Saxenda is an agonist or an antagonist. It stops this process from happening. So what it promises to do if you take it is avoid your own making of your own sugar, and it improves the leptin and insulin resistance that Dr. Lustig was talking about, which you can have because of just obesity itself. You become more insulin resistant and leptin resistant, and this kind of mitigates that, so that you're going to be able to use your sugars better than you are using them. Saxenda is the drug that's been labeled for weight loss, or the other name for it is lorgatitude. There is another drug called Victoza that is not, it is essentially Saxenda, but a higher dose that's used for the same reason, for insulin resistance, for diabetes. you have to be careful what you're taking. Anyway, it promises a weight loss of, I only saw 5 to 10%. Now, I've seen some people say, yes, that's the direct effect, but overall, it's more like a 40%. I don't know. I think the jury's still out there. But the idea is that it will improve this whole thing so that there won't be weight gain, hyperinsulinemia and weight gain, that it'll mitigate that whole process. Problem with it is, alongside with the fact that it might have some issues with pancreatitis and thyroid tumors, is that it's daily injection and it's very expensive. So people might take it, lose some weight, but they have to continue to take it in order for that weight loss to continue. So even this drug, which has the most promise, I'm a little bit hesitant to talk about. So those are that's all I want to say about those drugs. So I've talked about the amphetamines, the oldest and actually the most effective while you're taking them, the craving blockers, the fat blockers, and the psychotropics, and then these hormone-based drugs. Of course, the standard treatment, as I said, the behavioral one of just going on a diet, which is, basically we've been using the moderation. I know that I'm preaching to the converted here, but I've just given you a whole list of medications that are somewhat helpful, but only while you're taking them, often very expensive, lots of negative side effects. And the effect is maybe tops 40% of weight loss. Yes, significant if we're believing the optimistic estimates. If we just follow a food plan that actually supports an absence of sugar and refined starches, we don't have those cravings that we need to suppress in the first place. And those are food plans that will be anything from the 12-step program diets that are offered, like Gray Sheet has one, OA, well, no, not OA, but there's various food plans, OA How, that give their own plans, or you can just go on the internet. And there's insulin or leptin resistant plans. There's the paleo or raw food, which just by its nature takes away much of the processed food and some sugars. Real food, the keto, which is a real focus on away from carbs. All of these plans are probably, I think, effective for food addiction. And if you take away the cravings, you don't need the meds. You don't need the meds. So I think I think I might just end there by saying that medications are there, but it is no silver bullet. There are some promising avenues, but nothing, they all pale as far as I'm concerned to the efficacy of just stopping the food that is causing the craving. And then you don't have any of those side effects. Okay, I think that's it. Esther, take it away with questions.
Thank you. I am here. I took a little time to get myself off of mute. Okay, everybody. So we have, thank you, Vera. I always love this lecture of yours. It shows me that there's a lot of trying from the medical industry to find the magic pill, and what I feel you show in this, that there's no magic pill as you state. Yeah. So here is so one question was there. I'm not sure if you already addressed that. What's the role of Ritalin?
Oh yes. Okay. So Ritalin is one of the first. It's an amphetamine. And it's an amphetamine. It's one of the early ones. I guess it's very similar to Vyvanse in that it's primarily used for attention deficit, but it might be used, I want to say unscrupulously, because it's not in labeled use that you're allowed to use it. We're not officially allowed to use a stimulant for weight loss, but like I said, it gets done through, if you say, well, I'm using it for the attention deficit effect and the binge eating effect, then I can use it. And because it's an amphetamine, it's an appetite suppressant. It's that simple. However, it only works until you stop using it. That's why my cocaine and crystal meth addicts who are essentially taking Ritalin on steroids gain weight as soon as they stop.
Okay. So there is Annalise raising her hand, but we can't get you on line to talk. So if you want to ask a question, please do. And while we wait for that, we have, oh, here's Annalise. I'm surprised you did not talk about phentermine and Contrave.
Oh, right. I'm sorry. Yes, you're right. I forgot. That's a combo drug. Thank you.
Yeah.
I jumped ahead, and yes, I'm just going to quickly see the combo. Yes, thank you. Thank you. That's the other big one. So there's Vyvanse, there's Saxenda, and there's Contrave. Thank you. So Contrave is basically a combination of the two drugs I've already talked about: naltrexone, which is the craving blocker for opiates, endorphins, and buprone, which is Wellbutrin, which is the atypical antidepressant that has a appetite neutral or appetite with flattening effect.
Okay.
Yeah.
Thank you.
Those are the three big ones that you're going to see now, and thank you for bringing that up.
Okay, then there is a Courtney Younglove, obesity medicine here. I use anti-obesity medications and find them very helpful while I am teaching patients about the biochemistry of their body and help them develop behaviors. Most of them eventually wean off the medication on their own, figuring out that they don't need them after a while. At first, though, it can be a huge help.
You know, I think that's a very worthwhile point. It's almost the same point that we can make for bariatric surgery. It can be a tremendous motivator to see quick success. And, you know, if that were the case, I would be much more favorable to this. And, you know, you're working with somebody where there's that goal in mind. My experience is, unfortunately, that especially in the medical world, I don't know if you're a medical clinician, the focus is much more on meds and not on the sort of behavioral pathway, so that these meds are a bridge rather than the answer. And if they're a bridge, just like surgery, okay. But if it's the answer, there's no silver bullet. I don't know if you want to respond back, but I think we're on the same page there.
Thank you for that. So then there's this last one question here. Is there a statement or official position by Overeaters Anonymous on any of this info? And I don't think.
My guess is that there would be no official statement, because I think OA, like all the 12-step programs, don't want to stand in the way of medical intervention. I mean, I think they're really clear about that. Individuals may feel that way, but I'm pretty sure that the 12-step program would be, especially OA, which is very open to many approaches. You find a sponsor that will agree with the medication regime you're on, and you're good to go, and you're considered abstinent like anybody else. I think they're very careful about that. It might be individuals who aren't, but the actual organization would be. But I'm going to take the stand, because I'm not speaking on behalf of the 12-step program with my hesitations about these drugs, because essentially, if they're used as the answer, I don't think they're effective enough. But like our last question was, can be a good bridge.
Mm-hmm. Well, Courtney, the one with the question there before, is a board certified by the American Board of Obesity Medicine. So,
oh, wow.
Yeah.
Okay. Oh, thank you. That's great. But
yeah.
Can I say something about that? That is I have a lot of hope with the board certification now, because I wouldn't have had hope, but I've been seeing more and more people beginning to speak out, especially, I mean, with the whole keto craze. They often, I don't know, Courtney, if you're a part of the keto community, but that seems to be turning it's like that's the avenue that the medical intervention is starting to, if there is any openness, that seems to be where it is. And I find that very exciting. Although I don't follow a keto specifically, planner. I wouldn't advocate specifically that only. I'm very encouraged by the new bariatric certificates that are coming out now. So good. You must be one of them.
Well, thank you, Dr. Vera Tarman from Toronto, and I love seeing the back window on your garden, and I have fond memories, and there's the cat.
And cat, yes. Okay.
Okay, so I will turn off this recording at this point, and